like you better, if you have a patient in your chair, and I would want you to know this, something that needs to go within the hospital, and it is important, like we as surgeons have to realize if we're going to call something emergent, it better be emergent as well because we're competing with other surgeons and surgeries to go immediately in the operating room. So it really needs to be in this category with these symptoms. So I would just know those things. And that's everything from the infection lectures. Any questions? Okay. So next we're going to get into alveoloplasty and the pre-prosthetic surgeries. And let me just flip through this. Sorry, hold on one second. So over-aggressive reduction of the palatal torus is going to give you, basically you're creating a cleft palate. So it's going to be an oral, like a palatal nasal fistula or communication. It's not going to be an oral antral. So it's not an oral antral, that's a maxillary sinus. So oral antral, if you see that, I want you to know that just the anatomy, that's like if you're taking out a maxillary molar and you get an OA communication. But if you have a palatal torus, it's really tough because you're going through the palate anatomy-wise into the nose. So just make sure you know the difference between that. And that's why those can be very tough surgeries. So it's like a palatal nasal communication, not an oral antral. The next question, let's think, hyperplastic. Oh, so I just want you to make sure you know, and I've just put the one word fissuratum, a little bit of differences between the fissuratum and the hyperplasia as far as this is caused by an ill-fitting denture. Now, both of them are, but they're both not going to be on the question. So if I'm giving you a bunch of different diagnoses to do alveoloplasty or pre-prosthetic surgery, just know that an epulis fissuratum comes from an ill-fitting denture. So obviously, if someone has something like this in their mouth but doesn't wear a denture, I mean, I'm not getting into a biopsy. We're not going to get you into a trick question with that, but just know that that's from an ill-fitting denture. Just know that rongeurs and bone files are used for alveoloplasty. And obviously, there's not going to be both of those on the answer choices, but just know that that's something you can use. Long-term edentulosum, I would just memorize this list. There's going to be something on there that doesn't make sense, so I'm just helping you. That's an easy slide to memorize. Just understand what happens with someone has extractions, they have bone resorption, like what are you going to expect? What are you going to anticipate? So obviously the question will be focused on all the things will be correct except one. So should just be hopefully something you're not only memorizing, but kind of understanding, because that's important as a dentist. Remember I talked about a little bit, particularly if you're removing the fissuratum, this is important on a maxillary. You don't want to overclose because you're going to close up that vestibule. So a lot of times you need to have that denture to seat and let it scar down. So if you got an epulis fissuratum on the maxillary or even the mandibular anterior and you're cutting out that tissue, you don't want to just take all this tissue and pull it down because you're going to close the lip in the vestibule. So that's really important to know because we do see a lot of these, and sometimes the prosthodontists are like, why didn't you close it? So, that's to preserve the vestibule, and you would want to seat a denture or some sort of stent afterwards. Next part, let's see. Okay, so you need to make sure you know that the maxillary tuberosity, you need to define whether, when you get into the clinic, make sure you understand whether it's bone or soft tissue. So someone that's been edentulous for years but has this really thick hyperplastic tissue in the maxillary tuberosity region, they might have it reduced just soft tissue, or it could be bone. So that's just the one kind of pre-prosthetic surgery that can involve both. And so that was the point of understanding that. Timing, you need to know if you're going to plan to do alveoloplasty at a later date, so you do full mouth extractions or extractions, and don't plan for alveoloplasty, you have to let those sockets heal, tissue heal, and it's usually within 6 to 10 weeks to go back and start fresh. So that's just a time frame you want to know, very straightforward. As far as where you want to think about where you're going to have the most problems with exostosis is in the maxillary molar area. It's just literature shown that's the most predominant area. If you're going to be taking out teeth and you're worried about fitting a denture and RPD, focus on the 14, number 3 region. I know I have a picture here of the mandibular anterior just because it looks nice, but this is the main area, usually in the maxillary molar. So a palatal torus, now I talked about, and I don't want you to get confused, wearing a stent or a denture to prevent overscarring, but if you had any alveoloplasty procedure that would be good for healing, like pain-wise, like think about pain and having a raw surface of tissue that's not healing, a palatal torus, it's really important to wear a stent to help with healing and pain and soft tissue protection. So it's a little bit different than overclosure. So those are the two differences between that, and it will not be confusing on the test. You're not going to see a question about a stent and have palatal torus and epulis fissuratum, but you might see them separately. I wouldn't do that to make it confusing, but it's just part of that understanding. Any questions about the pre-prosthetic surgery? Okay, so getting into the biopsy, I wanted you to know that if I have a question about, if I gave you a bunch of different terminology, you need to pick out one that just goes with malignancy. And probably you're going to see like erythroplakia, because I think that's really important. And so the other things that might be associated with oral cancer would be very obviously not applicable. So if you had to memorize something, memorize that. There's some questions on incisional and excisional biopsy. So remember, I'm going one ahead of here. Okay, so you need to make sure you know words that go with cancer as well, and I think that's important. Large, fast-growing, aggressive, erythroplakia, firm, indurated, large, aggressive. So just remember these words. I mean, these are things you just need to know, not only for just a test and straight memorization, when a patient's explaining to you at their history, there's a purpose for this, and I think these are very important terminology to know and understand. And that kind of goes along with erythroplakia, and then knowing that as well for cancer. For excisional soft tissue biopsy, it really needs to be, if you're removing in a tissue and completely, you need to make sure it's small and it's benign, and you get a little bit of normal tissue. So, I mean, excisional biopsy, if there was a couple choices, the choice would fall into this category. So obviously something that's larger than a centimeter, that's doesn't fall into this category would be wrong. So the memory excisional biopsy would fall into this specific outline. And that's the same with incisional biopsy. So understand when you would want to do an incisional biopsy. One thing that gets those students a little bit confused, so say you have a small ulcer of the tongue. It's in the tongue, it's indurated, it's firm, it's erythroplakia looking, so it meets all the classifications. It could be oral cancer, but it might be less than a centimeter. You still want to do an incisional biopsy, because I talked about this in class, because the head and neck cancer surgeons or oral surgeons that do head and neck cancer need to be able to define the size of the lesion. If you eradicate it and they just see some big scar there, the staging of their cancer could change. I mean, so it's really important. You just want to get a good sample of that. So that's the big thing to know as far as incisional biopsy. Not only does it, the only thing that could be less than a centimeter might be concerning for malignancy. So just make sure you understand that concept. And then I think, like, again, I'm just focusing really on oral cancer here. We don't want to observe and just wait on something that looks like an oral cancer. Now, if someone comes in and they're like, well, I don't know how long I've had this little papule here, this little nodule, maybe I bit my lip, let's just wait, or, you know, I'm not ready for the biopsy right now, it's okay to watch it. But if someone fits into, again, all of those things I keep telling you to study, they need a biopsy right now. We don't wait for them. We don't just say, oh, let's just go and get this done down the road. They need a biopsy immediately. So that's kind of, again, the key things. I'm just trying to focus on what's important. I would just know these definitions I told you in class. I might have a slide on that or a test question on that. It should be hopefully an easy one to get right. Fine needle, I might have said you didn't need to know this, so I'll just tell you, if you see a question like this, I mean, you should study it, and I put it on the study guide for the students that aren't here. But you want to make sure this is being done in a location where there might be anatomical damage, like if someone's got a parotid lesion, you might see that, a very specific parotid lesion. You'd want to do a fine needle biopsy, get an idea of whether it's cancer or non-cancerous cells, because you don't want to go in there and take a big sample of tissue in an aesthetic area, an area you could make someone paralyzed with their facial nerve. So that kind of helps the surgeons plan their surgery to know whether it's malignant, non-malignant, and that's what the purpose of a fine needle biopsy would do. So Mirage staging, you know, if I'm just going to have a definition, like if someone's at risk, they have like these things in here, and the answer is going to be, is it stage 0, 1, 2, or 3? I mean, you just need to know these definitions. And again, hopefully, if you're not here, if the students aren't here, I mean, this is just straight from the study guide. Just know these definitions. So if someone, this is a really basic way of understanding Mirage. So you want to know what would cause it. So someone's got to have some osseous damage. Just know these little key features here. So if someone's going to develop Mirage, they're on the medications, and then just kind of read that there. They have to have, because the medications inhibit osteoclast recruitment or reduce the lifespan of them, or maybe they're not helping kind of angiogenesis go and signal that blood supply, they're going to get this abnormal bone turnover, or no bone turnover, if you will, and they're going to get necrosis. So the question will kind of just be following that pathway, very basic. I'm not having you memorize the previous slides with like more of the pharmacology about the pharmacokinetics of like how those medications work. I think as a second year student, just know this slide, kind of some basic overview, and you don't need to memorize those other slides. So as far as prevention of osteoretinocrosis, just know that, you know, ideally it would be nice always to wait 3 weeks after dental surgery. I would not have both of these choices. I'm not a crazy person for testing you. So, but just know the standard is at least a week to 14 days. So 2 weeks, 1 to 2 weeks is optimal. In the most basic areas, we would want to wait 2 weeks, 1 to 2 weeks. But the test question will not be. It'll be like 1 day, like 6 months. So I'm not here to confuse you, but as you sitting in here and having patients that might need this, I mean, if you can at least wait a week to 2 weeks before they have the radiation, that's really where we want it. So prevention strategies, I'm going to stay with the non-cancer. So say someone comes in your clinic and they're about to start Fosamax or some kind of medication. What do? The biggest thing is you want to optimize their health and educate them, not scare them. Because I went into that, like, we don't want to scare patients that, oh my gosh, you're going to start this osteoporosis medication and you're going to get Mirage and all these bad things are going to happen. That's not what we're here for. So if you're trying to help someone kind of prevent Mirage, kind of understand it, they're starting a medication, no big deal, but here's a little background. You want to have optimal oral health, good hygiene, good checks. Education is really important. So just focus on that column right there. As far as someone, let me see where I was going with this question. Sorry, give me 1 second.